Welcome back to episode 3 here at Men Explained. Josh and I have a very special guest today. We have Amy Pearlman, who is the director of Men's Health Program and a clinical assistant professor of urology at the University of Iowa City. She has a bachelor's in neuroscience from the University of Miami, her MD from the Baylor College of Medicine, and did residency in urology at the Hospital of University of Pennsylvania. So we are super excited to talk to her today. We're going to dive into some TRT, testosterone replacement therapy. We're going to dive into some fertility, talk about some of the things that she sees, and get a little bit more about her background. So Amy, welcome to the show.
Happy to be here live from Iowa City.
Oh yeah, we was waiting for the Go Hawks right from the top.
Man, I didn't know you were a fellow neuroscientist. That's awesome. I have a BS in neuroscience too. So
yeah, keep me honest. Did I have all that right? I kind of fumbled through it, but that's your.
Yeah, you made it sound really boring.
Oh, I love the honesty. Yeah.
I mean, yeah, I did a lot of training. You know, I did maybe 15 years of training. 10 of that was, within the medical field. I did an additional year of specialty training after my urology residency. And the body is a complicated thing. Most of what I do today, I actually didn't learn in training. I've learned from people like you, patients in my office. That's where I've really gotten the valuable information.
what was your fellowship in?
In men's health and prosthetic urology, infertility, reconstruction.
So in a very general sense, I have a burning question that I have to ask, but we have to just.
Oh, you should see a urologist.
Wow, that's
I
hilarious.
Can something, but
she gets it to you. Okay, so just in medical terms for the listeners, what is urology and what do you specialize in exactly?
Urology is the study of the genital system and the urinary system. In all genders, we think about urology perhaps as being only for men, but everyone has, or for the most part, has kidneys and bladders and ureters and genitalia. And actually, a lot of the work that I do within urology is caring for our transgender patient population. So really anyone along that gender spectrum. We think about the urinary system as being or the genital and urinary system as being anything from the adrenal gland to outside of the penis, but really it starts even higher than that, from the brain to the tip of the, urethra per se, because a lot of the signaling, well, that comes from the brain, even higher than the adrenal glands.
Yeah. So, and we're going to get into that because that's obviously a big component, and I think it gets widely overlooked, right? That the fact that there's a lot more going on north. So we're going to get into that. My burning question is, what attracted you to this specific branch of medicine? What is your why in pursuing this branch of genitourinary health? I had to practice that, but tell us about what led you here.
I like talking about sex and sensitive subjects, and people think that the stuff that I deal with on a daily basis are, oh my God, why would you want to talk about it? And you see genitals and penises and vaginas all the time. Who would ever choose that job? The reality is, when you think about all the different topics that are taboo and sensitive, well, let's name some of those. Weight, whether someone is overweight, normal weight, underweight, death and dying, cancer, all of those topics are sensitive. Drug abuse, domestic violence. And so when I think about the stuff that I get to talk about on a daily basis, most of what I do makes people feel better, both about themselves and about their relationships. I have a lot of tools in my toolbox. That's why I feel really lucky too, because for a lot of what I do, there are very few people that I can't help. But that's based on the thousands, hundreds of thousands of people who have put in the research, development, time, and resources to create those tools. And I have those tools at my disposal. So I feel like I can help a lot of my patients. But when I talk to trainees and they're trying to figure out, what subspecialty within urology they want to do, or even medical students are trying to figure out what they want to specialize in, I tell them, what do you like to talk about? What do you want to talk about 30 to 50 times a day, several days a week? And that should be the field that you go into. Because even though there are other types of surgeries that I like to do, that's not where the majority of my time is spent. The majority of my time is spent sitting down with patients, talking about those meaningful concerns that affect their quality of life, and educating community members.
Very cool. Very cool. So you talked a lot about the patients that you see and being able to help them. And obviously it's something that you're really passionate about. I wondered if you could kind of talk about the patients that you see. You know, what is their age range? What are the symptoms that they're experiencing? Like how do they arrive in your office?
Yeah, I would say it takes a lot of courage for a lot of the guys to end up in my office. And, part of my goals are doing, podcasts like this are to say, hey, man, you're not alone. You have the same concerns of everyone walking around this undergrad campus. I see the pictures of health in my office. I see athletes and former athletes and engineers and farmers. And, I really see the whole gamut from late adolescents up until men in their 90s. And the questions are all the same, which I think is kind of surprising. They're worded a little bit differently. People use different terms and they're phrased a little bit differently, but they're all based on the same questions, which are, I've noticed something different. Am I normal? Is this just due to age? And is there anything you can do to help me? But I have 70-year-olds that are asking the same questions as my 20-year-olds having to do with their genital and urinary system. My hope is that they don't wait until they're 70 before they get those answers, just because we have all those different tools that we can use to help them. So the common things that I see in my office, and I like to term them the 5 S's of men's health: sex, streams, steroids, sperm, sleep. You could even extend that to say size and sex reassignment surgery, to name a few others. But really having anything to do with how the penis works, orgasm, ejaculation, urinary system, and the penis in general.
Yeah, the 5 or the 7, almost 8 S's, that pretty well covers it, I think, to be honest. Okay, so now the big cornerstone here, the big thing is, how do you get them to really open up, right? That's a wide age range, and you said you don't want them to wait till they're 70. Yeah, this is a pride thing. This is something that you're obviously very versed in. Apart from knowing that you have really good tools, resources, and coping strategies to get around this stuff, how do you get them to really just open up and be vulnerable and honest about it?
Mm-hmm. I verbalize those scary terms before I make the man do it. And I'll give you an example. I can tell for the most part why someone is coming in to see me. It'll say in their chart, erectile dysfunction, premature ejaculation. Sometimes it may say something else and they're coming in to talk about a different concern. And so what I'll do is, walk into the room. I used to do a nice handshake, but now I'll, maybe do a namaste and, sit down. And I introduce myself and I say, hey, I'm Amy Pearlman. I'm a men's health specialist. I understand you're coming in today to talk about sexual health concerns. Before we get into the reason for today's visit, why don't we just get some basic information out of the way? So what medical problems do you have? Any issues with diabetes, high blood pressure? What prior surgeries have you had? So I try, and I don't do this all the time, but I try to talk about those topics that are not as sensitive. So let's just get the basic information out. Let's start to develop that rapport. And then we'll get into the reason for the visit. But when I go back to that reason for the visit, I'm the one saying, I hear, I understand you're coming in to talk about sexual health concerns. So let's talk about your erections, any issues getting and or maintaining erections. Whereas as opposed, and not to say that it's a wrong thing to do, and what we learn in training is to start always with an open-ended question. But that's not always the right answer. So if I were to walk into the room and say, hey, I'm Dr. Pearlman, what can I help you out with today? And you get a guy in there who it's already taken him 2 years, to make and show up for this appointment. And then I'm making him sit in front of me. I'm a young-ish woman, okay? And I have to make that guy tell me that his penis doesn't work. But so that's not how I run my practice. And so I just normalize it. Hey man, what's going on? What can I help you out with today? You know, I might add in some additional comments of, I don't know if this is going to make you feel better or worse, but you know, you're my noon appointment. I've seen 10 dudes verbalize the same concerns that you're coming in today. And this is just a Wednesday, you know, and sometimes people are like, oh my God, you mean that my penile pain, I'm not the only one? And I'm like, no, I literally see that all the time. And I think that's sometimes what people need to hear. The other thing that I'll ask if I'm not sure if I'm on the same page with the person in the room is I'll say, what are you hoping to get out of today's visit? And sometimes their response is, Doc, I want you to tell me I don't have cancer. Sometimes it's, I want you to fix my pain. Sometimes it's, I want a diagnosis. And oftentimes it's, I want to know all three of those answers. And that's where we can also get on the same page, is because I can easily say, well, you don't have cancer, you know, but if they're looking for other things, it's understanding, what are your goals from today's visit? You've already seen 5 urologists. What do you want to be different about today?
Yeah, one of the things that really stands out to me about that, because it's really this field's biggest challenge, right? That's the biggest hump that we're faced with is just to be open about it, be honest about it, right? And you mentioned that you call it out first. There's a term in like negotiating that I learned about where you it's going to sound bad, but when you label the negative, you make it okay. You kind of give people an out when you label a negative, and it sounds like you do that by leading and doing that first. The other thing too, and I think it's probably just as important, if not even more, is that whole, oh, I'm not the only one going through this. That is huge as well. So it's really cool that that's the way that you lead with that, because you can help a lot of people with that approach.
Yeah, and I think some people are surprised. I was chit-chatting with a patient of mine yesterday, and he said, Amy, the first question out of your mouth when I met you was, how are your erections? And I was like, Steve, I don't remember that being the first question. And he was like, yeah, it was the first question. Do you say that to everyone? I'm like, I have no recollection. I have no idea. Sometimes, yeah, I probably do. You know, I think most people enjoy my candidness and my openness. I have no doubt that there are some people who come in and might be a little bit put off by how I interact with people, but I read the room. And if someone's not picking up what I'm putting down, and maybe I'm a little too passionate and out there, I'll certainly tone it down. So during the entire conversation with a person in the office, I try to elicit my emotional intelligence, you know, and tailor my choice of words accordingly. The other thing that I found to be really useful is to create this digital footprint. And I mean, like YouTube videos, for example, and a Twitter presence and an Instagram. And my hope is that with YouTube and some of these other digital programming that I'm doing with webinars, for example, are that they can hear my message before they meet me in person. They can watch one of my YouTube videos where I'm demonstrating on something like this. I'm demonstrating on the first visit when you come to see.
Yeah, what is that? What do you got there? What is that? You're just bringing that in.
It's
you got
model.
Yeah.
This is a penis. This guy actually has, we'll call him Billy. He has a penile implant in.
Okay.
But he's a good model for how I do the physical exam. And I'll outline that in the YouTube videos. When you come in for the initial visit, these are the types of questions I'm going to ask you. This is what the physical exam looks like, so that people can prepare accordingly. You know, I certainly have some patients who come in and I ask you to do a physical exam because they're coming in with some genital concern, and they're a little surprised that I want to do the exam. And I'll never force someone into doing the exam, because that would not be the right thing to do. But also, I think just guys, I mean, we as women, we're so used to it. It's like we go to see a gynecologist, they ask to do a pelvic exam. I mean, we're not surprised by that. But a lot of men are surprised that we ask them to, you know, bring their bottoms down. So I think if they see that beforehand, they can mentally prepare. They can see what I look like, my age, you know, that just helps them mentally prepare to go into the office. Okay, I'm going to see a young woman today to talk about my sexual health concerns. Now, I also realize that there are plenty of men who have no interest in seeing someone like me, right? And that's why we have people of all genders to treat male sexual dysfunction. And I'm so grateful that we have a diverse, group of healthcare providers who want to see these patients. And that's my goal, is like, if someone doesn't feel comfortable seeing me, finding someone with whom they feel comfortable seeing. So I think there's a healthcare provider for everyone, depending on who they feel comfortable seeing.
You mentioned that, I mean, this sounds like a plentiful network that they have available to them, in addition to the resources and the tools and the treatment. I'd venture to guess that you're not only just treating or working with the patient. You would potentially be working with spouses from a relationship perspective. Can you talk a little bit about that, just outside of what you're working with on an individual basis with the patient? Like, do you have other people that they work with from relationships and stuff like that?
Yeah, absolutely. It's one of the most important things I did when I started Iowa is I created a referral network. And I'm humble enough in what my expertise is to know that even though I have a wide range of expertise, it's also fairly limited. And I'm limited in terms of other aspects too. I mean, I run essentially a surgical clinic. I mean, I treat a lot of medical conditions, certainly low testosterone, no one's going to surgery for that. But I am also a surgeon. And even though I incorporate some counseling techniques in my office, like, my expertise is not in counseling. And so I have several members of my team I refer out into the community who are couples counselors and sex therapists, and every person in my network I've sat down with, either through Zoom or in person. I understand, like, hey, what types of patients do you like to see? And what is the access like in your clinic? And what do your conversations look like? Because then I can match my patients and give them recommendations on who I think they might gel with the most. So I have like 3 sex therapists in the community, and depending on who's sitting across from me and they ask for a recommendation, I might say, I think Erin's going to be your gal, and I'll give that person Erin's contact information. And in part, that's one of my most important roles, is to help advocate for my patients and find providers who can help each of their individual issues. Before COVID, it was nice because a lot of the partners would come in for the visits. And I think for a lot of what we talk about, because it's all quality of life concerns, it can be overwhelming for patients. And some of my patients come in and their concerns are, I have erectile dysfunction, I have penile curvature, I have right testicular pain, I have low libido, and I have lower urinary tract symptoms. And each one of those male specific, concern is like a 1-hour conversation, because I will talk about everything from lifestyle modification to surgery for each one of those. And that is overwhelming. And so when a guy's coming in for the office, especially for that initial visit, nobody ever sat down with him to say, hey, John, we're going to talk about your body today. This is how it works. So when he's coming to me with those 6 concerns, I can't learn everything about him and talk about every treatment option and expect that John's going to be able to tell me what he wants to do about it. It's just too much, And so really for that first visit, it's just building that rapport of, I'm just here to find out your information today, but also the partner sitting there, for the partner, that partner doesn't know what's going on with John's body either. And so it's really nice when both parties are there, because if John hasn't been able to get good erections, I think it's nice for Sally to hear that it's not her. It's not that he's not attracted to her anymore. It's, hey, let's talk about your erectile tissue and what needs to work well in terms of blood vessels and veins in order to get an erection. And Sally, it's not you. And you're hearing that from a doctor, But the other thing too is, partners can be really good advocates for their loved ones. And wow, or the guys who have partners advocating for them, they are the luckiest ones. Because they can go home and talk it out and vet it out. And oftentimes the partners, at least from what my patients say, are the ones who make a lot of these decisions. So now I might have the partners on the phone or through a video visit. But I think part of my role in being a woman in men's health is to really advocate for the partner. And, one example I can give for that is like with penile implant surgery. I have some guys who think, oh, once I put a penile implant in them, all of a sudden their partner's going to want it all day, every day. And I have to sometimes sit down with those guys to say, it's not all about the penis. And there are ways that, that your partner might want intimacy that is not necessarily penovaginal penetration. But also, I think being a woman, it helps me tell the guy, like, hey, man, your penis, it's good. Like, you got plenty, like, from a woman's standpoint, you got plenty of length, you got plenty of growth. I know it's not what you're used to when you were 19 years old, but the vagina is not that big. And so that's where I think I can also play a role as a woman, talking to a man in the office. But then lastly, I think some men just want a little female attention. And I don't mean that in like a seductive, creepy type of way. I just think that men, especially if they get older, if they don't have a partner, men actually want to talk. They have a lot to say. They just never been given the stage to say it. And in my office, I allow them that stage.
I think that's great. I think I'm a huge advocate of my patients when their wives come into the clinic with them, for a couple of reasons. One, because it's I always tell them, like, this is a team effort. This is both of you. This is affecting both of you while you're here. And then the women are just better at opening up, and they're willing to talk. And I kind of use them as like a truth serum sometimes. Like, okay, so thanks, Bob. That's now okay, Jill. Now tell me, does that make sense to you? And they'll kind of go, yeah. They're, nah, not really. And so it's actually really helpful because they want their husbands to be better, and to feel better and to function better. And so it's like, when you can get both people on board, I feel like the success rate's higher, and you see them both come in 2 months, and everybody's happier, and it's awesome. It's great. I love it.
You mentioned COVID early on, a few minutes ago, and we don't have to go too far down that road, but I'm wondering how this has gone for you in the past year, because things have moved. Has it been more like telehealth? Like, how have you overcame this in your line of work over the past year?
Last year, I had to cancel a lot of my elective surgeries, but a lot of those patients, we ended up, rescheduling probably most of those after we were able to get them back on the schedule. I would say, COVID gave me some additional time to be a little bit more creative. That's where I spent a lot of time building the digital content so that I could still educate my patients, even if they couldn't see me in person in the office. And now it's really helped me, even for patients who see me in the office. I can say, hey, we're going to talk about a lot today. And sometimes you just have to hear it several times. So why don't you go to my YouTube channel and just watch this video a few more times? And I'm giving them the message. It's all the same shared message. So it's not like conflicting things here from what they see in the office. And then if I direct them to someone else's video, it's all a similar message. And so I would say, COVID also, I do a lot of research. And it kind of forced me to think more creatively about how I was going to enroll patients in research studies. And the nice thing about being able to do things like on online surveys is you can reach a global audience. Whereas, as in person, if I'm enrolling patients from my clinic, I'm limited to the patients who see me in clinic. And when you use platforms like Reddit and closed Facebook groups, you get people from all over the country and all over the world. And I think it's a much more meaningful experience.
Yeah, I couldn't agree. I couldn't agree more. So speaking of like testosterone replacement therapy, or TRT, I guess, is that the common first stop for people before they come in and see you the first time? Is it been the first line of defense? Can you kind of talk about that a little bit?
Yeah, I get a lot of people coming in saying, I'm concerned that I have low T, but that's not really their concern. Their concerns are, I'm tired, I'm 35. Is this the best it's ever going to get? Did I reach my peak when I was 22 in college? I am working hard during the day, but I'm exhausted when I get home, and I have 2 kids and I want to play with them, but I can't. And I want to help my wife in the kitchen, cook dinner, but I'm too tired. And my sex drive is down a little bit. My erections aren't quite what they used to be, but I guess I'm 35, and I guess this is just what it's going to be like. And so when they Google that, or they see, direct to consumer marketing. And so they label it as low T, but they're coming in with the concerns that everybody have. It's just men have never had an opportunity to be plugged into the healthcare system. we as women get plugged in for the most part pretty early out of necessity. I mean, I remember when I was probably 17 years old and my mother said, Amy, it's time to see a gynecologist. And I was like, no, I like and you dread that visit leading up and, up to that visit, but I was plugged in. So whenever, women go to see a provider, whether it's because they start their period or they're going through a pregnancy, they have someone that they see on a somewhat regular basis where they can say, hey, doctor, I noticed this change in vaginal discharge, or I noticed this change with some lower abdominal pain. What do you think is going on? So we have milestones in our lives. And I guess my question for each of you are, what is the male milestone equivalent that the guy says it's time to see a doctor?
That's a good question. I think it varies. From, I guess, is your question from like an age standpoint or like symptom standpoint?
Yeah, I mean, it's like what happens in your life that says when it's like you got to see a doctor. I mean, it's when you develop symptoms.
Sure, yeah. I would say it's fatigue, or the big one is low sex drive.
Yeah,
guys really they get pretty sideways about that.
In, and then because when you look on TV and pornography, men aren't supposed to have low sex drive, and yet it's what fills both of our clinics.
Mm-hmm.
And not to say it's not always something that we need to treat. It depends on how bothersome it is, but some people are just like, is this normal? Like, aren't I supposed to be like a vigorous man in the bedroom? And I guess yes and no. It kind of changes depending on what's going on in that person's life. But there are no real milestones that the man says, okay, I need to see a doctor. So they come in when there are symptoms. Mm-hmm. And a lot of these symptoms are common, but it doesn't mean that anyone has to suffer with them. And I think just men don't necessarily know how to verbalize their concerns. I think some men come in and they are overweight and they want to lose weight, and they don't know how to verbalize that to their healthcare provider, saying something like, okay, I'm 35 years old. I work out 5 days a week with cardio and I lift weights, and I can't get this darn 10 pounds off. And 5 years ago, if I just skipped a meal, I would lose 5 pounds. And so what happened over the last 5 years? And when guys are working out hard and they're trying to eat healthy and do what they need to do on a daily basis, and they're not seeing changes in their body, it's frustrating. Right. And so it's like you kind of label that as I'm worried about low T. In reality, your concern is I want to feel better. I want to make some gains at the gym because I'm putting the work, God damn it,
Yeah, and, you're speaking right to my heart here. Because I've been on testosterone now for a year. And I was super, super stubborn about admitting that, hey, this is probably affecting me. So I tried to eat my way around it, sleep my way around it, deadlifts, sprints, the stuff you buy at GNC. I tried everything, and it just turns out that it was a genetic predisposition. So I just had to okay, Pride, it's time to you to go to kind of take a break. And it's been the best decision that I've ever made, honestly. But
I think sorry to step in. I think. It's interesting that you say people come in with a problem and there's this label of low T. And I think one of the things that guys, as my generation, 35, even a little bit older, you'd sit around.
I didn't know you were 35.
No, I'm 37. I'm 37. So
we should have her guess.
Yeah,
that would have been fun.
But you have these guys come in, and I think they're just used to seeing dad kind of as they kind of got older. Dad would do a little bit less. He'd sit on the couch and he'd doze off at 5:30 after dinner, and dad would be in bed at 9. He'd maybe wake up at 4 and he'd go back to sleep. And they just kind of, well, it's just part of getting older, right? And then it starts to happen to us, and you're like,
slowly.
Sometimes it's quickly though. That's that's the hard part. Is sometimes it is a slow burn. Sometimes it's a quick turn. But I think guys want to, I guess you could say, a diagnosis or a label or a reason or what's going on. And so that low T thing, while it's kind of a cute term, it's a little frustrating as a provider, because you're like, yeah, potentially, but you've got real issues in your life, and you obviously are not enjoying that. We can define low T all day long, and what is that to you? What is that to me? But hey, let's talk about what's going on with you, why it's happening, and what we can do about it. And I think it is really helpful when guys do actually come in and they see, and we can show them objective data that their testosterone is not, they're otherwise healthy, but their testosterone is low. And then we can develop a treatment plan for them, and they can respond to that. I think that's a really good point that you brought up of the low T label, but then there's actually a whole lot under
it's
there.
Multifaceted.
Yeah, tip of the iceberg type stuff.
Probably as providers, I can't.
As a concern in a way that doesn't embarrass them,
Mhm.
right? So they can easily call up and say, oh, I'm worried about low T, rather than I'm worried about my strained relationship, my erectile dysfunction, my low libido. So it's just a door for them to walk into, you know, and there are so many doors that men enter into to get into the healthcare system. And so we who specialize in men's health, we have to take advantage of the door that some of these men will walk into to say, hey, you belong here too.
I agree.
So one of the things that I wanted to talk about is, or ask you about is, I think that there's a general tendency for us to focus on what's going on below the belt buckle. It's all in the pants, right? But can you talk a little bit about what else is going on? Like maybe in the brain and how things are, talk about the whole system, if you would.
Yeah, so usually what I see, and I do some infertility, but most of it is a signaling problem. And we can look at that based on lab work. And we'll usually check if we're working someone up for hormone concerns, we'll check like a total testosterone level. And if that's low or low normal, then we'll check some additional levels to figure out where might the problem be. The level that we'll check after testosterone is going to be something called luteinizing hormone, or LH. And depending on what that level is, that'll tell us, is it a testicular problem or is it a signaling problem? If that LH number is high, then it means, well, the brain is trying to signal, it's just the testicles are not producing. So that means that person has a testicular problem. And that could be from a genetic disorder. That could be from an infection in the testicles, like mumps or orchitis, if they had mumps involving the testicles when they were young. Could be from chemo or radiation therapy. Could be from having a history of testicular cancer or any sort of scrotal or testicular surgery in the past. Those are the more common ones that we see. But for the most part, it's actually rare in my office that I see the primary testicular problem. Most of the time, that LH number comes back as within the normal range or low normal, which means, and even if that LH number is normal, that's actually an inappropriate response to a low testosterone level. If the brain sees that low testosterone level, that pituitary should say, hey, we got to ramp up production to stimulate down below. So that LH should go up. So if it's normal or low, that is a signaling problem or a pituitary problem. There can be a lot of reasons to have a pituitary problem. We have no way of saying exactly why someone has a signaling problem, even though that's most of what I see. It could be from a traumatic brain injury. It could be from a recent illness, from obesity, really any other sort of comorbid condition can affect that. And so even though we say it's a signaling problem, we can't really diagnose it for, any more than that to say this is exactly what caused it. But those are the majority of the patients that I see. And then we'll check a prolactin. That's another pituitary hormone. And that's indicated if that LH level is low or low normal. So most of the time I'm checking a prolactin because the LH is usually in that range anyway. I also check a baseline estrogen level because estrogen is really important in men. Me, as a female, I have testosterone and estrogen, but my major sex hormone is estrogen. In men, the majority of that sex hormone is going to be testosterone, but some of that testosterone gets converted to estrogen. And when that estrogen is out of whack, perhaps when we put someone on testosterone therapy and we drive up that testosterone level, that's really where we see a lot of the bothersome side effects: mood changes, breast tenderness, breast swelling, acne, fluid retention, flushing, just kind of feeling crummy. And so I will usually check that baseline estrogen level as well, just to see where we're at in case I'm going to start someone on something like an aromatase inhibitor from the beginning. But the point is, we're checking all of those other hormones to get a better sense of what are the other signaling mechanisms going on that might be affecting the testicles as the main driver or producer of testosterone production. Now, other things that cause signaling problems are going to be things like stress. Now, if you were to ask most men, do you feel stressed out? Do you feel depressed? Do you feel anxious? most men won't know what I'm talking about, or they might say no. It's just because a lot of men, they don't think about it that way. You know, if you were to ask a 22-year-old athlete, do you feel stressed out? He's probably going to say no. But if he was studying the previous 10 hours for a big exam and he has a gymnastics meet this weekend, in some way, shape, or form, he's probably feeling some level of stress. The other thing too is we are just so used to this chronic state of stress that we don't know when we're stressed out anymore because it's become such a chronic problem. But stress and anxiety and frustration and excitement and happiness, those are all chemical signals. Those are neurotransmitter reactions that are going on that are sending signals to other parts of our body. And that's why when we say that stress increases risk for things like heart disease, it's not stress in and of itself. It's that stress increases cortisol and all of the downstream effects that then increase heart disease. But that can also have an effect on the testicular production of testosterone.
I think that's great. Yeah, I try to explain that to guys all the time, especially guys that are even on treatment. So kind of the two biggest killers of your testosterone outside of, genetic abnormalities or trauma is stress and sleep. Like if you're high stress all the time and you don't sleep, it's an uphill battle even when you are on treatment, because your body just chews through that stuff so fast. And if you're not on treatment, and it's just a vicious cycle of I'm stressed all day, I'm tired all day, and then I don't sleep well because I'm stressed all day. And so we do discuss those lifestyle modifications and stress management, and it's easier said than done. But yeah, I think that's a really important point to bring up.
So we're talking.
That really do well is when they take let's say they meditate or they practice mindfulness. Like those are the guys where testosterone therapy can really be game changers because they have a handle on all of these other factors. Where I see that my patients don't get the benefits of testosterone that they're crossing their fingers for are when they have high blood pressure that they're not controlling and diabetes that they're not controlling. And let's say they're a firefighter and they have a poor sleep schedule. It's like, I can't fix those things with testosterone.
Mm. Yep. Those are good conversations that we have. And the just managing comorbidities, I always tell guys like, yeah, if you have sleep apnea and you're not treating it, we probably should consider one, stopping testosterone because it's only going to make it worse. But then two, it's like, how much money do you want to waste in time and energy? Because if you're not sleeping, and especially if you're not breathing when you're sleeping, like you're never going to respond to the treatment. So, and I always tell them, I'm like, you know what? If this made you lose weight and made you feel like Superman, like there would be a line around the block. Like I would never be able to close, and I'd fly to work in a gold-plated helicopter. But you still got to do this stuff for yourself. Like you have to get up and do the work. Yeah. You've got to eat right. You've got to do those mindfulness, exercise, stress management, and you will optimize. You'll need less testosterone to get a better response, and you'll feel better around the clock. I mean, nobody wants to hear that, but it's just the way it is.
No, because we love a quick fix.
I know, but that just in life, it's true. But just in life,
sure.
If you just eat well and exercise and sleep, it takes care of a lot of problems. So, I
have a quote here. That I read from an article, and I think it's from a few years back. So keep me honest here, but I believe this is something that came from you. It says, as a community of urologists, I think we all understand the important roles that we play in our abilities to provide accessible, streamlined care to our patients. These unprecedented times call for unprecedented educational opportunities. If we hope to encourage the next generation to pursue fields in urology, now more than ever, we have an eager and captive audience wanting to learn what our field and specialists have to offer. I'm saying yes to all the teaching opportunities, and I hope you do too. Here's my question for you. We know that you're saying yes. How do you get your eager and captive audience to say yes? Did I get you? Did I stump you? Oh, I thought I had one. Thought I stumped
you.
For
a hot second, bro.
That article was posted in the Urology Times, and it was promoting some of the educational work that I do for physician assistants. And there's no other group of providers that I am more passionate about teaching than PAs.
Yes.
And I'll give you some
physician
examples.
Single.
Correct.
Yeah.
We are, urologists, a lot of us, not me in particular, but are going to be retiring in the next few years. So access is going to be a problem. But even more than that, I'm a surgeon. And a lot of my colleagues and the people that I trained with, we like to operate. But most of what we do doesn't need a knife. It's just some subset of that population. So when I think about the people that I'm interested in training, my mission is to educate people in a way that they can work at their highest level of licensure. And in order to do that, you have to define what that highest level of licensure means. So in my clinic, when I treat urinary symptoms and low testosterone and Peyronie's disease and erectile dysfunction, most of those conversations and treatment options don't require an operating room, which means PAs and NPs can take most of my patients through that entire conversation. And then I really only need to be involved if they need surgery, which means I can work at my highest licensure of operating and enrolling patients in clinical trials and writing research grants and educating people and educating other providers. And it also allows the nurse practitioner and the PA to work at their highest level of licensure, which is education, community education, doing procedures in the office. And so I realize that, and the fun thing about teaching PAs as well is that they don't want to be in the operating room doing the surgeries that I do. They want to master the clinic visit. And I want to work with people that want to talk to my patients because my patients want to talk. And that's the beauty of working with, PAs and NPs is if you find the ones that are interested in talking about men's health, then everyone wins. The provider wins, the surgeon wins, the patient wins, and that patient's family and friends win. So it's just really finding the people who want to have these discussions with patients and to take them through the entire treatment process. So that article was kind of a call to action to people like industry to say, hey, you have this product for Peyronie's disease and you're reaching out to surgeons like me, trying to get us surgeons to leave the operating room to do procedures in the office. And my call to action was you should go to the PAs and NPs and teach them how to do it. And it's called to industry to, companies like Boston Scientific, to say, hey, it's really important to educate people like me and urology fellows, but let's see how we can also educate PAs and NPs.
That's awesome. And I'm gonna agree with you and thank you for the advocacy, because that's huge for me as a PA. But one of the things I think that needs to be clarified or cleared up there is that the sense that I get from you is that you don't want to use a PA or an NP as somebody just to do the scut work in the clinic. I think it's a good way, because there's always the argument in the PA community about the name, right? And I think you truly use the term probably better for you would be something like a physician extender. They're taking your place in clinic as the physician, not I'm not going to call myself a physician, but again, doing the physician extension, doing the clinic work, helping with that, doing the in-clinic procedures. And then like in a really big case, if you didn't have anybody, you could pull a PA into the OR, but likely not, obviously, because there's plenty of residents and things to teach. And I think that's awesome because it really does, because you don't need to be there to kind of micromanage, and it really does allow PAs and NPs to practice at their highest level of licensure, gives them autonomy. And that's awesome. And I think, I think the University of Iowa, where you're at, is probably the best place for PA education because they work with the med students in school. And then, so the docs who are residents are like, oh yeah, I've been with a PA for 2.5 years already. Like I'm used to them. I understand that. And I think that's awesome from a standpoint, from my viewpoint. I think that's fantastic because it really does. It really marries that relationship much better than some older docs who don't really see PAs that way.
Yeah, we're all taking care of the same patients.
Mm-hmm.
And there are plenty of patients out there. I mean, even within, our local area here around my institution, I mean, we're barely even taking care of the men within our system already. So there's no competition at all in any way, shape, or form. It's all the same patient that we're trying to take care of. And my job is to educate people and then get out of the way and not slow people down because, I'm there as a resource, but most of what I do can be done by people who are well-trained and passionate.
Yeah, you're speaking right to Josh's heart here because this is right in his wheelhouse. This is how we came to the same table about men's issues is because this is his world. And he cares deeply about talking about men's issues. So we really appreciate your time today. We know that you're busy and you're obviously doing a lot of really cool things for men. Where can our listeners go to learn more about you and find out more about what we've talked about today?
Probably the easiest ways to find out some of the content and what I'm up to is I have a Twitter page, which is at Amy Pearlman 1. I have an Instagram, which is, I'll look it up here in a second.
How do you spell your last name?
Amy Pearlman MD. And my YouTube channel, you can just search Amy Pearlman. A lot of what I do with that YouTube channel is just reach out to other providers in the community to reinforce the really good work that they're doing. And so you can look out for some of those videos.
So can you spell your last name so people go to the right page? They're looking for the right person.
So like Pearl and then man.
So PEA.
We'll post the links if you're cool with that. We'll just post them, we'll lay them over the video. That's all we have. But again, thank you so much for your time and for what you're doing for men's health. It's incredible. We're deeply grateful.
Yeah, thank you for your time, Doc. We really appreciate it. This was awesome.
Awesome. Y'all have a good night.
You too.
All right, you too. See ya.
Thanks for tuning into the episode, guys. We appreciate you listening. Do us a favor, if you would hit the like button below and subscribe. You can also hit the little bell. That'll send you a notification when we post a new episode. In addition, if you have any questions, concerns, or comments, shoot us an email at hosts, that's plural, HOSTS, at menexplainedpodcast.com, or go check out menexplainedpodcast.com. Do us a favor, just share this with anybody you think that they would like it. We appreciate you tuning in. We'll catch you next time.